Hello, sir. Hey, how you doing?
How you doing?
All right, all right. You my MSA for today?
I am.
All right,
Let me go
sure.
ahead and let me rename this.
All right. Let me close my door real quick. Give me 1 second.
Yeah.
All right. How you doing, man?
Good. I'm trying to get my background like yours, but
Oh, okay. It's all good. No,
whenever I smile, you see.
oh, yeah, I don't think you need that, man. All right. Let me see what we got here. Riley Grosso. I don't think she's part. I don't see her as one of the moderators. This is your first one, or were you on some yesterday?
Yeah, I was on some yesterday, but
Okay.
I wasn't really. The ones yesterday, they didn't really need an MSA for it.
Okay.
And kind of we were kicked out early because it was more of an exam.
Gotcha. Okay.
Webinar, yeah. So to protect
Okay.
the integrity of the exam, they didn't want us to be in
Okay.
there.
Okay.
Yeah.
All right. Well, I'm gonna make you a co-host so you can help out.
Okay.
How do you pronounce your name?
Nana Kwame.
Nana Kwame.
Yeah.
All right. Cool.
All
right.
Yeah. Or Kwame for short.
Okay. Cool.
Yeah.
All right. Let me see what we got in here.
Oh, okay. Riley.
Yeah. I think she might be. I don't have her. The only person that I have as a moderator is Jessica Schoen. So there's usually more people, but I didn't get any. I don't see any more on here. So
Okay.
I'm gonna assume that she's not part of the. Yeah.
No, she is. She's part of the planning
panel?
committee.
Okay.
Not the panel, but she is part of the planning committee for it.
Oh, okay. Oh, you got more information than I do. I don't see that. You working off the spreadsheet?
I'm going off the spreadsheet. The SAEM session sign up spreadsheet, right?
Right.
Yeah, that one. Let's see.
Huh.
Yeah. Actually, you're right. I don't see. I don't see her name.
Yeah, that's what I'm saying. I see Viral Patel.
Right. I see.
As one of the moderators, and then if you go to the website, there's a Jessica Schoen.
Right.
Which my guess is a speaker.
Presenter, I believe.
Right.
Yeah. But I don't see her on it. No.
All right, then I'm gonna have her hang tight unless somebody else advises me otherwise.
Let me I can message her.
Okay. Where you at for medical school, Kwame?
I'm at Ross University School of Medicine. Actually, it's one of the Caribbean schools out in Barbados right now.
Man, that's where my parents are from, bro.
Really, your parents are Asian?
St. Christ Church, yes, sir. Yes,
oh wow,
sir.
Wow.
Yeah, man. Yes. My mom is from Guyana, and my dad is from Barbados.
Wow.
Yeah, wow. That's crazy that you
that's crazy.
Right.
Man, but yeah, so we're out there. We're out there now, but we do 2 years out there and then 2 years here. So currently, I'm in Chicago, Illinois.
Okay. Oh yeah. Okay.
Emergency medicine rotation.
All right. So we here too then. Yeah, that's where we're based out. We're in
you guys are. We're
in Des Plaines.
And Des Plaines. Okay.
Right, yeah,
I
just
think
west of the city.
Des
Yeah.
Plaines, isn't it like it's a big city in Illinois, right?
No, not really. It's probably
No,
about 50, maybe 40,000.
but
Yeah.
there's a lot of corporations in Des Plaines,
Yes,
right?
yeah, it's
Okay,
mostly, yeah,
that's
it's
why,
mostly
because I see
corporate.
that name a lot.
Yeah,
I see that name a lot.
and the casino's right next door in Rosemont. So
Right.
yeah. So yep. Oh wait, it looked like she might have dipped. Hold on 1 second. Let me see what happened. Oh yeah, she left.
Mm.
All right, I guess she'll be back. Uh-oh.
Did I ask her if she'll be moderating as well?
Which one are you texting?
Riley. The one
Oh
that
yeah, you
just
can
left.
ask her. Yeah, that way if she is, then I'll let her in. All right. What time is it? All right, I'm gonna give them another 3 minutes, and then I'm gonna have one of these emergency folks shoot an email to her because they're supposed to be on a half hour early,
Yeah, yeah.
and that's gonna start making me nervous.
Yeah. But I don't know, because there's another one going on right now.
Yeah, there's several. So but
Yeah.
unless she's part of that one, she need to dip out of there and get this one going.
Yeah.
Let me go on and just see what's going on with these guys.
Oh, so she said she will not. I'm going to attend as a human participant. Okay.
Got it. That's what I thought. Okay.
Got it. Got it. Okay. All right. So what's my, as far as my role? What's my role as far
Yeah,
as how
so
to
you know what, I usually gauge it, Kwame, by like what the needs are of the moderator and or the
Okay.
speaker. Usually they come in with a whole plan and we just stand by for any other emergencies, which makes our job a lot easier. However, if they want us to admit people while they're speaking, or if maybe on my end I got to set up a poll. I'm strongly urging these speakers not to have breakout rooms because it's a little complicated with all the rooms that we got going on. So already,
Yeah.
so hopefully they don't need that. Otherwise than that, we just mute, go off camera and hang tight.
Sounds
This
good.
is a short one. I had 2 4-hour ones yesterday. Those are killers. I don't know how long yours was, but
Man.
Yeah, those are the hard ones, man. You gotta sit for 4 hours
Man.
and just
Yeah,
listen.
this is a 20-minute one.
Yeah, so in and out, easy peasy.
Yeah.
Right.
Have the presenters usually been on time for these, or
Yeah, they're usually like they're waiting when I get ready. Like as soon as I open up, they're popping in. See, that's why I'm getting a little nervous because now we're almost at 10:02 and we haven't heard from anybody.
Yeah.
So yeah, I don't know what's going on with that. So I'm gonna double check with my internal people here and see what's going on.
Gotcha.
You want to get into emergency medicine, man?
Yeah. That's my ultimate current goal.
That's the end game.
At the moment, yeah. And after that, I'm trying to go into education, and then after that, I'm trying to take it to Ghana because that's where my parents.
Oh, that's where you from?
That's where the name comes from. Yeah, the Nana Kwame. Yeah,
Oh,
Kwame
okay.
means born on a Saturday, where in Ghana.
Oh, sweet. Okay. Dang.
Yeah,
Yeah.
yeah,
No,
and
that's my
yeah.
mom's birthplace right there, man.
Oh yeah,
Yep. Yeah, that's where my mom was from, and then she went to
in
Barbados.
Ghana.
In Ghana. Yeah.
Wow,
Yeah. And then
wow,
met my dad in Barbados. So
wow. That is. What's your mom's name?
Joycelyn. It's like Jocelyn here, but it was Joycelyn here when she came. Oh, here she goes right here.
Okay,
Perfect.
okay.
All right.
Wow.
Hi, Dr. Sean.
Hello.
Hey, how are you?
Hi, Dr. Joey. How are you?
This is medical student ambassador Kwame. I'm George here at SAM. Nice to meet you.
Nice to meet you.
Nice
too.
to meet you.
All right, and I'm going to make you a co-host, so you should have those privileges now.
Okay, perfect.
And I think we're waiting on, is it Viral? I thought I saw your moderator for this,
Oh,
Viral Patel.
So,
perhaps.
No.
I don't know.
Okay. All right. So are you solo then? You don't have anybody? Did
Just
you have
me. Yeah.
Okay. Oh, you had, okay. Good deal. Okay. Okay.
How's it been going so far?
The meeting in general?
Mhm.
Yeah, it's been a little crazy to say the least. I got to be honest, Dr. Sean, I'm much rather be on site. I thought that was hard. But,
Yeah.
that it's like a walk in the park in comparison to doing all this technical, with the Zoom and the polls and the breakout rooms and let's just all get together in a room and let's get it done. And yeah, I can't wait for New Orleans next year. I got to be honest.
Yeah.
Yeah.
that'll be my first time in New Orleans, actually. So,
Oh, nice.
looking forward to it.
So it looks like the moderator's in the waiting room.
Oh, let's see. Participants. Yep. Good call. Hello.
Hi there.
Hey, how you doing?
Good. How are you?
I'm good, thanks. All right. So you're the moderator for today then?
That's right.
All right. I'm going to give you co-host privileges as well. And I think that makes our group here. So we'll just wait for our participants and we're good to go.
Perfect.
All right. So Kwame and I'll just, as soon as we get started, is it easier for us do you want us to just handle admitting people in so you can talk, Dr. Sean? And
Sure.
okay, that way you don't have to worry about that. And then I don't know how you handle, do you have any chats going or did you have any, are you doing it or are you just going to present?
I'm just going to talk. It's a little 20-minute lecture essentially. So
good deal. Nice and easy.
I'll just share my screen and show my slides and
perfect. All right. Okay. Thanks, Kwame. How much time do we have left? If there's anybody else, let's wait till 11 to let everybody in. I'm assuming there's nobody else coming in regards to, right? All right.
I would think so.
Okay.
So I can close out of the Juno link for this, right? We're just going to be doing this on Zoom.
Yep.
And then I will introduce you at 11
Okay.
and you'll have 20 minutes. And then do you think you'll end early for questions, or you're going to go the whole time?
I think it's going to be close, but there might be a couple minutes for questions.
Okay, sounds good.
All right, Dr. Patel, you're on it.
Should we wait for a couple minutes?
Oh
or-
no, I'm just saying you're on top of it. Not
Okay.
yeah, you're good. All right. Dr. Sean, have you had a chance to get it? Are you registered as well? Have you been attending other sessions?
Yeah, I did some pre-conference courses yesterday.
How has it been for you?
It's good. This is my first virtual conference, so it was a little bit
It's a little
little bit-
interesting, right? A little different.
interesting.
Yeah. It's not quite the same as going to the hotel and going in those rooms, and it just,
Yeah.
But I'm glad we were able to put it on as a society, and people get some CME, and
Mhm.
it's the times we're living in, so yeah, make do. Are you a ASAP member as well?
Mhm.
Yeah, we're supposed to be in Boston hopefully this year.
Mhm.
So
That's-
let's see how that works
Okay.
out. Yeah, I'm kind of looking forward to it. I'm cooped up too long.
Yeah.
I'm ready to get on a plane. How much time we got left? About 4 minutes. All right, I'm gonna hop off. Kwame, you can hop off too. We'll just hang back. If you guys need anything, just shoot us a chat or just say, hey, we'll be in listening.
Okay, sounds good.
All right, guys. Thanks. Good luck.
Thanks.
All right.
All right, good afternoon, everybody. My name is Viral Patel. I'm a member of the program committee. I'll be moderating this session. I'm excited to have Dr. Schoen with us today. She's currently at the Mayo Clinic, did her fellowship in medical simulation at the Lifespan Medical Simulation Center at Brown University, and is now a faculty at Mayo Clinic and director of the Mayo Clinic Emergency Medicine Community Simulation Program. So Dr. Schoen, whenever you're ready, you can take over the screen, and it's all you.
Sounds good. All right. Can everybody see my slides? Yes, good. All right. So thank you very much for that wonderful introduction. As he said, my name is Jessica Shane, and I'm at the Mayo Clinic Health System in Rochester, Minnesota. I have a lot of simulation background and do most of my education via simulation, specifically with in situ simulation. And so what I want to talk about today is ways that we can apply in situ simulation in our own emergency departments. We're going to start with just a brief discussion of what in situ simulation is and how that compares with center-based simulation. We'll identify some key features of in situ simulation that promote its applications clinically, and then we're going to discuss ways that we can apply in situ simulation in our own emergency departments. I don't have any disclosures. So center-based simulation is describing simulation that takes place in a simulation center, either a high-tech facility or just one room, but typically it's arranged to reflect the environment where the participants work. There's a lot of really great things about center-based simulation. The space is customizable, so you can change the layout or the content of the room to reflect diverse care sites. It's minimally disruptive because it's off-site, it's not in that clinical work environment, so you're not going to disrupt patient care or everyday workflow. And it's feasible to do direct observation. So our simulation center at Mayo has observation rooms and debrief rooms that are connected via one-way glass and are also wired for live streaming video. So we can have additional observers or learners or instructors watch the simulation take place in real time without crowding or distracting, and then they can all participate as a group together in the debrief. On the other hand, though, there are some downsides. Scheduling might be difficult if your competition for learner groups for the same space is high. Additionally, if you're dealing with folks that don't live near the simulation center and have to travel, coming to the simulation center for that training might not be feasible. Several of our community sites are over an hour away from our simulation center, so it's a big ask to get people to come out to the simulation center. But the biggest issue, at least in my mind, is that despite our best efforts, this mock clinical environment might not really replicate the actual clinical environment closely enough. The size of the room, the layout of the room, the equipment that we have at the simulation center just might not mirror what those participants actually have in their clinical environment close enough. And that can make it difficult for them to suspend disbelief and engage in the scenario. In situ simulation refers to simulations that take place in the actual clinical environment where the participants work. This allows teams to take care of these patients with their normal team members, using their own equipment, following their own workflows. Scheduling and access may be a little bit easier because you have folks that don't have to travel to the simulation center. They're much more readily able to come to something at their home site. You may also be able to involve learners who are on duty that day because they're already on site, whereas they wouldn't be available for training at the simulation center. The big thing, though, that in situ simulation is really great at is assessing systems and workflow issues that you simply can't uncover when you're in a simulation center. And we're going to talk about that in more detail in just a few minutes. In situ simulation is not perfect, though, and it's not as straightforward as it may sound. You don't have to worry about getting your participants to the simulation center, but now you have the reverse issue. You have to get your staff, your faculty, your techs, and your equipment out to your site. If your site is far away or doesn't have any of its own personnel or equipment, that can be a pretty daunting task. Direct observation is going to be more difficult. There is no debrief room with one-way glass, and the size of the room that you're using might limit, if any, the number of observers that you can accommodate. The biggest issue is that it's potentially disruptive. You're taking over a space that should be used for patient care at that time. So you really have to think about what time of day and what day of the week and what the patient volumes typically are in order to schedule something like this. You also have to think about what equipment you're using and whether that's something that might need to be pulled for actual patient care and how you're going to deal with that if that happens. We always have a takedown process that's quick in case the flow changes and the room is needed for patient care so that we can bail out quickly. We always have a list of no-go criteria, and we always have a backup space identified on site just in case we can't use the in situ space that we were hoping for. So is in situ simulation really worth all of that effort? Absolutely. In situ simulation can be very versatile and very valuable as a tool. So we're going to talk about why in situ simulation is so great. The first thing I want to talk about is realism. And we talked about this just briefly when we were talking about pros and cons. But for a simulation to be successful, we need our learners to be engaged. We also need some level of authenticity. And realism is a very key component of both engagement and authenticity. So what's more realistic than taking care of patients in your own shop with your own team and your own equipment, following your own workflows, right? In this picture here, we were running a simulation at one of the community sites where I work. We have 2 teams taking care of 2 patients in the same recess bay. We have 2 telemedicine devices with 2 consultations going at the same time. So this is about as real as it gets to take care of this type of patient in this site with these resources. And this really gets this group to engage in the learning and then apply what they've learned right away. So those theoretical conversations that people have about, okay, this went really well in the simulation center, but how do I apply this where I work? And I don't have that piece of equipment, or I don't have that resource. That doesn't happen in this scenario, because anything that we uncover in terms of a question or a process improvement perspective, we can talk about it as it pertains to that specific environment and that specific case. And these guys can take what they've learned and apply it later that day or the next day, because they've just gone through it and they know how to tweak what they've learned. So in situ simulation improves realism and then therefore engagement and the overall learning experience, and allows for practical application of that knowledge. Second thing that simulation is really great for on the in situ side is stressing the system, because you're running that case within that system. So we're going to talk specifically about latent safety threats and mock codes. A latent safety threat is a system-based patient safety threat that could come up at any point in time, and that is unrecognized by staff or administrators. There was one study where a group did a series of in situ simulation cases over the course of a 12-year period. And they ran 90 cases overall in that period of time, and they discovered 73 latent safety threats. It's one threat for every 1.2 sims that they ran, which is huge. And these were things like missing or malfunctioning equipment, medications that were not stocked appropriately, team members that either didn't respond at all or were delayed in their response. All of these things are fixable issues that are unique to that site that cause a delay or may adversely affect patient care that we simply just wouldn't discover if we did this in a simulation center. Mock codes allow for a different way to stress the system. So in these situations, you have a mock code or a mock trauma activation. You notify everybody the way that you normally would, and they come and they respond to the event. And that allows us to look at our alert systems and our responses and make sure that everything's functional and responding the way that it should. Did everybody who was supposed to get notified get notified? Did they respond in an appropriate period of time? Did they bring the equipment with them that they're supposed to bring? We can also look at resource utilization. Are there people who are called to respond that aren't really necessary? Are there people who aren't called to respond but should be on that list? And how do we make those changes? Those are also questions that are difficult to answer when you're doing this in a simulation center. So now that we've had a chance to kind of discuss what in situ simulation is and what the benefits of in situ simulation are, I want to go over a few ways that we can apply this today in our own emergency department. Education and training, I think, is the first thing that comes to mind as the most globally useful thing that simulation is for. And when I think education, I typically think first of medical management. So in situ simulation is a great way to practice those high acuity, low opportunity or halo events, not just with regard to how do we manage this rare or scary pathology in general, but how do I manage this pathology in my shop with my team and my resources or lack thereof. It's also a great way to provide continuous education and brush up on those core competencies or core curriculum. In some cases, it may be a mandate from your department or your hospital or your professional society to regularly review something. It might be regular review of pediatric cases for a non-pediatric center, things like that. But those are a great way to get education through in situ simulation as well. When I think of training, I think more of skills, procedural skills, and maintenance of skills. In situ simulation can be a really great way to review those skills. You can fold those skills into a case and perform the skill in real time as the case unfolds. You can have a skills station separately that allows everybody to go through it, and you can check them off, and you can even get your competencies for the hospital checked off that way. It's also a great opportunity for multidisciplinary team training. Again, because you can get that same multidisciplinary team that would normally take care of these patients together in their normal setting and have them work together. And you can use cases that are designed to focus them on teamwork skills more so than medical management. You can include things like questions or concerns so that they understand there's a mechanism for team members to voice concerns to the team leader during the case. You can practice closed loop communication. You can practice developing and sharing a mental model for the case so that everybody's on the same page at the same time. And it really allows these teams to come together in a way that's much more cohesive and probably more feasible than trying to get all of these folks over to your simulation center. Another application is with quality improvement. Now, in some cases, or to some degree, we do this with every simulation, right? We always evaluate our performance and we try to come up with ways to improve. We might uncover a latent safety threat and take some steps to address that. But those are usually secondary to the point or the goal of the simulation. And they're usually ultimately the responsibility of one or two individuals. So how do we leverage in situ simulation in a more systematic way to assess and address quality of care gaps? And I want to share with you the way that we did this recently in one of our community sites. So we used in situ simulation to essentially perform a gap analysis. A gap analysis is a way to determine the difference between the current state, the way things are, and the desired state, or how you would like them to be. Sometimes you can use chart reviews or incident reporting systems, but in our case, we used in situ simulation. So we partnered with a group called IMPACTS, which stands for Improving Pediatric Acute Care Through Simulation, to run some baseline simulations in our emergency department, one of which was pediatric septic shock. And this group had run these cases in their shop previously, and they set these up so that there are 6 critical actions that they identified based on the Surviving Sepsis campaign. And in their shop, when they ran their baseline simulations, they found that only 47% of teams completed all 6 of those critical actions. And the biggest issue for them was IV fluid bolus administration and doing that appropriately. So we already know in general that there are gaps in care here. And then they came to our emergency department and ran these cases with us, scored in the same way. And we discovered that IV fluid boluses were an issue for us too. So we've identified our gap, IV fluid boluses for pediatric septic shock. We're not doing that as successfully as we could be. Now we have to decide why. What is driving that gap? Is this a knowledge issue? Our team doesn't know what the guidelines are. Is this a skills issue? We just don't know how to administer those fluids appropriately. Or is this a practice issue? We know what to do, we know how to do it, but we can't get it done in real life because there's some systems issue standing in the way. When we looked at our simulations and talked to our teams through debriefs, what we found is there were issues of all 3 of those at play for us. So our teams were familiar with the concept of a 20 cc per kilo bolus and 3 boluses before pressors, but they weren't familiar with the timeline part of that guideline. Each bolus should be in within 5 minutes and all 3 in a total of 15 minutes. From a practice perspective, at our institution, there's been a big push to put IV fluids on a pump for kids to avoid accidental fluid overload. But the pumps have a rate limit. And so trying to get 60 cc's per kilo in 15 minutes is very difficult with that rate limit in place. So in that case, we know what to do and we know how to do it. The system's not set up to allow us to do it successfully. We can go around the pump and use the IV push-pull fluid method for rapid administration of boluses in kids. but that's not a skill that most of our teams had. So a little bit of everything folded into this gap for us. And we took that knowledge and we designed a QI intervention specifically targeting IV fluid boluses in pediatric septic shock. So from a knowledge perspective, we came up with some video modules to teach our staff how to do push-pull fluid boluses. From a skills perspective, we set up some skill stations and we timed them and made sure that they were able to get the appropriate amount of fluids in 15 minutes. And then from a practice perspective, we talked with our local leadership and we said, hey, we know the pump is an issue. Can we go around the pump in this setting? Is that going to be acceptable? Depending on what your practice issue is, that's going to be a little bit trickier to address. So once we had everybody go through this intervention, we did a reassessment simulation with folks who had not completed baseline sim. So they were not familiar with the case, but they had gone through the quality improvement project. And what we found was that our overall success on appropriately giving IV fluids went up. So pre-intervention, we had a 25% overall compliance, 1 point for volume and rate, and 1 point for using the push-pull method. Post-intervention, we went up to 75% correct. We had 100% of teams use the push-pull method and 50% get the appropriate volume in the appropriate period of time versus 0% pre-intervention. So you can use this same cycle over and over again to reinforce what we've learned here, or you can look for different gaps in different areas. And then the last thing that I want to discuss is practice standardization. And we're going to look at 2 examples. The first is how to introduce a new practice at a single site. So at our institution, we have 2 sister campus hospitals that are about 25 minutes apart from each other. And a couple of years ago, obstetrics consolidated all of their inpatient services onto one of those campuses. So they moved everything from campus B over to campus A. Now, prior to that, any pregnant woman who was over 20 weeks gestation with a pregnancy-related concern that showed up went straight up to OB. Well, now campus B has no inpatient obstetric services, so all these patients are going to come to the emergency department. And the big concern was, what do we do if somebody shows up in labor? So there were 2 parts to this. The first part was we had to develop a protocol, a guideline for how do we manage these patients and what's their disposition going to be when they show up in the emergency department. And once that guideline's developed, we have to disseminate that to our staff. But this is a big multidisciplinary guideline change. So an email is not going to cut it. We needed an opportunity to run through it, see how it worked, figure out where the kinks were, and sort of tweak it as we went. Part 2 was we needed to re-educate our staff on this. This isn't a patient population we were used to seeing. So let's make sure that we can recognize active labor and that we know how to perform a vaginal delivery and that we know how to take care of a postpartum patient and that we know how to take care of a neonate, because this is going to be something that we're going to see now. So Situ simulation allowed us to do both things at once. We were able to run through the new protocol, practice all of that medical management, answer questions, come up with new questions and feed those back to leadership and alter that protocol until everybody was comfortable with this. And I'm happy to say that in the first year after this practice change went live, we had 3 vaginal deliveries in our emergency department. Historically, we had 0 ever. So 3 in a year is a lot. All 3 of them were relatively uneventful, and all 3 of those delivering providers had gone through our simulations trainings and felt that they were very well prepared for that scenario. We also managed to successfully transfer out 18 others, 7 of which delivered at their accepting facility. And then our second example, we're going to talk about practice standardization on a system-wide scale. So telemedicine, as I'm sure you know, is sort of a rapidly exploding area for medical care. And this is something that we have available to us in all of our emergency departments through our health system, but it's variably used, partly because it's new and teams aren't sure how to fold it into their workflow or how to use the technology, and partly because it's rapidly changing in terms of who you can call and why you would call them. So teams aren't always familiar with what the indications for consultation are. So how do we teach them how to do this and when to use it and show them that it's valuable? We started folding Situ simulation into our, we started folding telemedicine consultations into our Situ simulations. So our teams can practice using this technology in real time, interacting with the consultant in real time to manage that patient and really see the value of it. And we've surveyed some of them after they went through this training, and many of them said, yep, I have a better understanding of the technology and the workflow. I'm much more comfortable interacting with that consultant. And I really did feel like that consultant provided me with useful medical management assistance, and there was value in that consultant, in that consultation. So overall, they said, this was a really valuable thing. I'm glad I had an opportunity to practice with it, and I'm much more likely to use it again in the future. So went through a lot. Take home points for today. In situ simulation is simulation that's held on site in that clinical work environment. It increases realism and therefore learner engagement, and it allows you to assess systems and workflows in a way that you simply can't in a simulation center. And you can take this information and you can apply in situ simulation today in your own emergency department, not just for education and training, but also for quality improvement and practice standardization. Thank you very much for listening. And if we do have any time left, I'm happy to take some questions.
Thank you very much, Dr. Shane. Unfortunately, we are out of time, but if you want to stay on, I'm not sure, George, if maybe stay on for a couple minutes. Otherwise, thank you very much.
I'm happy to stay on if folks have questions.
I can do about 5 minutes if anybody has anything.
Hey, it's Jeff Siegelman from Emory. One of the challenges we've had has been, just getting time and space to do this in a busy ED, and also getting nursing buy-in. So especially that latter, I'm curious how you address that.
Yeah, so buy-in is definitely an issue. From a nursing perspective, and even from a clinician perspective, we offer CME or contact hour credits whenever we're able to do so. So a lot of this work is supported from the simulation center, or part of it is supported by the simulation center, even though we're taking our curriculum and our equipment out to these other sites. And so the simulation center has the ability to apply CME and contact hours credits through certification that they've done previously. In some of our sites, the nursing supervisors have bought into this as valuable, and say, so they're able to assign it as part of the nurse's schedule. And as long as it's a 4-hour education session, their rules allow them to pay the nurses for being there. So we've leveraged that quite a bit to get participation on the nursing end. In general, I'll say that once people go through it once or twice, they tend to start to buy into it on their own, and will sign up for it even if that monetary piece isn't there.
I have a question as well. So the point you made about the latent safety threats is really interesting, and how many you discovered along the way. And I can certainly see how a hospital and like a chief quality officer would be interested in this. Is this something that's been expanded to other departments in the hospital or other services?
So in our health system specifically, the emergency medicine department is doing most of this. We are slowly sort of branching out. We've had requests for in situ simulation from other departments as well. So we're trying to establish a similar network with obstetrics and with anesthesia. Whenever I run a case that involves other specialties, I try to pull staff from those specialties to get involved. And we almost always will have leadership from a department, whether that's a nursing leader or one of our sort of more administrative operations folks there. And part of their whole job is just to see what those pieces are in terms of how to address those things. We always come up with a report at the end that lists those latent safety threats and share those with local leadership so that they can address them. We haven't yet really come up with a formal mechanism, in the sense that we don't do these cases with the intent to discover latent safety threats and address them. We always do it with the intent to either educate or train based on topics that that site has requested that we cover, or a recent Sentinel event or something along those lines. And then we make sure that we bring forward those latent safety threats when we discover them.
Awesome. Thank you very much.
That would be one way to consider getting additional support for these, though. If this is something that you're showing that you're able to address, you might be able to get more either time or money support from the practice side of things rather than the education side of things.
Absolutely. Well, thank you very much, Dr. Shane. That was really enlightening. And thanks everyone that participated.
Thank you.